How exactly does patient selection play into dental malpractice?
Well, patient selection is important. We're going to discuss a lot of the different aspects of patient selection, a lot of different types of times when patient selection comes up. But in our MedPro claim database, we see that it has a big impact on the claim frequency and severity. And patient selection issues account for 14% of all of our cases and 16% of our total dollars paid. So we know that making a bad decision about bringing a patient into your practice can have a huge impact from a malpractice standpoint.
When it comes to a high-risk patient, how does that play into the patient selection process?
Yep. So the patients that we consider high risk from patient selection standpoint start with cosmetic procedures. Cosmetic dentistry is fairly risky. Emergency patients that present on an emergency basis can present you with different types of risks that can end up in a bad situation. Patients who are seeking second opinions, we've talked about that a couple of times throughout this series. Patients that are new to your practice, patients that are non-adherent to treatment plans or to suggestions from a clinical standpoint, and then patients that are disruptive or abusive in the practice kind of fill that category of patient selection that can cause issues going forward. And I'll kind of start with a claim that kind of sums up how patient selection can be problematic. So we had a patient, 17-year-old patient, who presented to Dr. B with a badly decayed tooth number 31. So presents kind of from an emergency standpoint, and Dr. B recommended a surgical extraction. And he informed the patient's mother that he would like to refer the patient to an oral surgeon. Well, in this particular scenario, the patient was on Medicaid, their benefits were just about to run out, and they wouldn't have had time to go see an oral surgeon and have that covered by Medicaid. So this is an emergency situation where now finances have come into play, and Dr. B, out of the goodness of his heart, decided that he would undertake this extraction that he really wasn't comfortable with from the start. So he undertook to do the extraction. There were significant issues. He ended up having to go a lot further in the removal than he had anticipated. It was a difficult extraction, and he ended up causing nerve damage to this particular patient. So what ended up happening was he ended up getting sued for something that started out as a kind gesture for a patient. So that emergent patient, he felt like he was outside of his comfort zone, but he still undertook to treat the patient and ended up getting sued. I like to say that no good deed goes unpunished, and in patient selection cases, we end up in that scenario a lot.
So you mentioned the different types of patients earlier to consider, when thinking about patient selection. And I'd love to dive into each of those a little bit more. So can we start with the cosmetic patients?
Sure. So cosmetic dentistry is obviously a needed and desired type of practice, but it tends to draw a fairly difficult patient. Let's just be upfront about it. So there are some things to consider when you're dealing in cosmetic dentistry. So you tend to have a patient who is more critical of the results that they receive.
Yeah.
They tend to be more demanding in terms of the results that they expect and what they want. They tend to be more vocal when there is dissatisfaction. They tend to be more apt to request refunds, which is a big problem in dentistry. The cosmetic patients tend to request those more often. They tend to be willing to file more board complaints. They tend to be willing to file malpractice cases a little bit sooner and a little bit easier. And they tend to file more negative reviews. So you're starting out in cosmetic dentistry with a difficult patient, let's just say that. So some of the risk strategies that we suggest that you implement with these types of patients: be candid, be honest, be forthright, be blunt with your patients about what the true expectations and outcomes that they should expect from whatever procedure it would be. Trying to sugarcoat those never works out well.
Yeah.
You have to. Basically, we suggest that you underpromise and overdeliver, not the other way around when it comes to cosmetic dentistry. Make sure that you discuss during the informed consent process the total length of time of the plan of care and the patient's responsibilities and what they should expect along that plan of care. A lot of these cosmetic procedures can be lengthy in time, and patients understand that there's a beginning and there's an end, but oftentimes they don't understand that there's a responsibility and a midpoint during the treatment where they have responsibilities and where things may not look like they want them to look. So the length of time and what they should expect during that length of time is important. Clearly define and discuss the patient's responsibilities in relation to the treatment plan. So making sure that you have a patient who is committed to follow through with the treatment plan. Again, if it's going to take 3 months to complete, make sure that we've got a patient who understands that it's going to take 3 months and that is willing to go throughout the 3-month process. Be upfront about expected costs, making sure that patients understand that it could change in the middle of treatment plan if things that are unexpected come up. So discussing finances on the front end is much easier than having to discuss them at the end.
Okay, so then let's move on to the next patient you mentioned earlier, which is the emergency one.
Yep, emergency patients. So, the emergency patients present a number of risks. And the start off, I want you to think about the fact that you don't have to see every emergency patient that comes through your door. We see a lot of dentists who get into trouble trying to help out patients in an emergent situation when they're outside of their comfort zone and doing more than they feel comfortable doing. So that's the first thing. If you feel uncomfortable, if you feel that you're outside of your comfort zone, my suggestion to you is to not treat them, send them to the emergency department. So the ethical standard of care for an emergency patient is to provide reasonable accommodations. And that can be pretty simply made. If referring to the emergency department is a reasonable accommodation. So again, your comfort level should dictate exactly how much you're willing to undertake with a particular patient. Make sure that if you do have an emergency patient that they understand if they're not a patient of record, that you're treating them only for the particular emergency treatment. And if you have concerns about the level of care that's needed, then pass on it. Oftentimes we have what I call the Band-Aid on a bullet hole scenario, where you have a patient who's coming in that has a significant number of dental issues, but they only want you to treat the one tooth that's bothering them at that time. That should raise the hair on the back of your neck and give you concerns about treating that particular emergency patient. And then trust your instincts. If you feel that this is a scenario that is outside of your comfort level, then opt to pass and send that patient on to the emergency department. And there's a case study that I use when I talk about emergency patients that's kind of pointed on these on that scenario of passing. So this case had a 25-year-old male patient with a history of diabetes and non-compliance to treatment in the dental office, and he showed up without an appointment. So this is walking in with an emergency. He needed an emergency extraction of tooth number 11. So this doctor had a full schedule that day, but again, kindness of his heart, went out of his way, saw the patient after hours, after the office had closed, to extract this tooth. He had indicated on his intake paperwork that his diabetes was controlled. So he extracted the tooth for the patient. There were a number of other issues that the patient had, but he extracted this tooth and this tooth only. Basically, the patient ended up with a significant infection, ended up in the hospital, and then it spiraled out of control, where he ended up spending a couple of days in the ICU. Everything came back to this initial tooth extraction. What they found out was when he was admitted to the hospital that his diabetes was uncontrolled, so he had blatantly lied on the intake paperwork. This is that scenario where you start with something that seems rather simple, a simple extraction, and you basically spiral it out of control, where you're dealing with a patient that isn't being candid with you up front, and you end up in a bad situation.
Well, then let's move on to the second opinions and
Right.
how that plays a factor in this topic.
Sure. So we've discussed this a couple of times throughout the series. Second opinions, they're common in dentistry, and they're necessary in dentistry. I mean, making sure that they're checking on necessity and comparing cost is a common undertaking in dentistry. But the hidden in second opinions can also be information seeking for a lawsuit or for a board complaint against another dentist. So be mindful if you have a patient that shows up who won't answer the simple questions. Who is your current dentist? When were you last seen as a patient? Why did you select my office for a second opinion? Why are you seeking a second opinion?
Yeah.
These are basic questions. If you've got a patient that's evasive on any of those, then that might be a situation where you choose to take a pass on providing a second opinion. So if you do decide to undertake giving a second opinion, we have a couple of risk strategies for you. First of all, stick to the facts. Don't speculate or guess. Try to get adequate clinical information. So if you can get previous treatment records for the patient, that would be great. Try to get both sides of the story. If you're trying to look at this patient's previous dental history and the patient's giving you one story, if it doesn't seem to fit right, don't hesitate to either look at previous dental records or to pick up the phone and call the previous treating dentist to find out. And then stay clear of any negative commentary. If you're giving a second opinion, give your professional opinion. Don't add anything to that opinion, particularly if it's negative commentary about the care that another dentist has provided.
All right. And I mean, that makes sense too. So let's move on to the new patients.
Right.
And dive into that one.
And this seems pretty simple. I understand, particularly if you're a younger dentist trying to build a practice, you kind of look at it and say, well, where is the risk in new patients? Well, oftentimes these new patients are an old patient to some other dentist. And so I think that all new patients should have some sort of intake interview just to make sure that the fit is right. The doctor-patient relationship, that the goals and objectives of the relationship are common to both parties. I know that that's not always possible, but I think that it's a good suggestion. Bringing in a patient who is complaining about the doctor that they're leaving should raise a red flag. And you need to understand that you are not required to take all comers. I mean, just because a patient calls your practice, you're not required to take them on. So be selective about patients that are showing up at your practice that have a significant history of 6 dentists in the last 2 years. That patient that shows up that's complaining about the dentist that they just left. Patients that show up that already have a treatment plan in mind. If they show up as the patient as doctor. Patients that have a history of non-adherence or non-compliance. Patients that are evasive about previous care or previous treatment or previous providers. And patients that refuse to allow you to have access to their dental history. All of those should raise red flags, and if you see those, be inquisitive, dig a little deeper, and if you feel uncomfortable, again, it's probably best to pass on those patients.
Yeah, so you mentioned in speaking about new patients that some new patients are other dentists' old patients.
Correct.
And part of that could be from non-adherence.
Right.
So what if you are a dentist and you have a current patient who is non-adherent? How do you go about that?
So these are really problematic patients, the non-adherent or non-compliant patient. So first of all, you have the right to terminate any patient who is non-compliant or non-adherent. If you're not seeing eye to eye on treatment plans, then you have the right to terminate that patient from your practice. As long as you're not violating state or federal laws or contractual obligations, you can terminate a patient for non-adherence. So you need to remember that a patient's non-adherence, even if discussed, even if you have a discussion with a patient about the fact that their oral hygiene is lacking or that they're not flossing and this is causing issues from a dental standpoint, even if you have a discussion, that doesn't absolve you from potential negligence that could come down the road from that non-adherence or non-compliance. So a patient that fits into that category that just isn't willing to do their part, I've mentioned in previous programs that we view dentistry as a team sport, and if you get a patient that isn't participating in their own dental care, then that might be a patient that needs to find dental treatment elsewhere. No good deed goes unpunished. The more that you keep this patient around and try to get them to be compliant, if they're missing appointments, failing to show up when they need to show up, and failing to participate in their own dentistry, then that might be a patient that you choose to move away from.
All right. And then our last patient, the disruptive and potentially abusive patient.
Yeah, so these are scary patients, and it shocks me how often dentists are willing to continue to treat patients that are disruptive or abusive. If you have a patient who is yelling, screaming at your staff, that is something that you don't need to put up with and that you shouldn't put up with, and it happens far too often. We get calls on the dental call line fairly routinely asking the question, can we terminate a patient who is in our practice that is really causing a ruckus in the practice? And the answer is yes. I think that very seldom have we had a dentist that calls and says, I can't believe that patient sued me. Most of the time it's, I knew it, and I should have terminated this patient from the practice when we had the opportunity. I think that what you'll find most often is that these patients take up an inordinate amount of your time. If they're disruptive to you as the dentist, and if they're verbally abusive to a dentist, you can only imagine how they must be to your staff.
Yeah.
And what we find is that it's a very small percentage of your patient population that falls into this abusive, disruptive category. But that when you get rid of them from your practice, you tend to have a much happier staff, a much happier patient population because they're disruptive to your other patients that are in your practice, and a much happier dentist. So, call and get some advice from MedPro about termination if you get to that point. But if you see this type of disruptive behavior, my suggestion is that you get on top of it very early. Let a patient know that that's not acceptable in your practice. If there isn't some immediate corrective action on their part, then my suggestion is that you move pretty quickly to terminate them from the practice.
Okay.